I think we can get started now. Welcome, everyone. My name is Adnan Hyder, and I'd like to welcome you all to this seminar. I must say the weather gave us incredible challenges in actually implementing the seminar, and I want to thank all of you for being so patient. It wasn't my fault. It wasn't the department's fault. The school is not responsible for the weather, at least last time I checked. So, but it's great that we are here. It's wonderful. And it's my pleasure to welcome you to the seminar on future of global health systems. I'm particularly pleased today because I think we have many reasons to celebrate, and I'm going to enunciate just a few of them in introducing this. First of all, we are celebrating 100 years of our school. So happy birthday to Johns Hopkins Bloomberg School of Public Health. Now, if that's not a good reason to celebrate, then the fact that we have our own alumni coming back and talking to us is indeed a reason. So we are so grateful that although our speaker will be introduced in a few minutes, that in fact our own graduates who have achieved important positions and done incredible work around the world come back and speak to not only faculty and staff and students, but also our community as well. I did want to acknowledge, however, that he's not the only alumni, our guest speaker, but we too, some of us are alumni of the school. And you'll be seeing some of that as well. I think a third reason to celebrate today is that we have dedicated this seminar to one of the individuals who was absolutely vital, not only to the Department of International Health, but also to the School of Public Health. And of course, I'm talking about Professor Bill Reinke. Dr. Reinke was indeed paramount in establishing the field of international health and helping establish our department. In fact, in terms of the academic programs, he played an absolutely vital role. Here I have for you one of his seminal papers, which is over 20 years old, and I wanted to read just a sentence or two from his writing. In this paper, he talked about how health programs should be effective in reaching their objectives and should do so through efficient use of scarce resources. Moreover, the benefits should be equitably distributed among the targeted beneficiaries. And for those of you who ever had the pleasure of being in his class, or more so, being in an exam with Dr. Reinke as one of your examiners, you know that all of these terminologies, you were asked to define them, explain them, and also provide objectively verifiable indicators for each one of them. And that, I think, was a training that many of us, including, I think, our speaker for today, has gone through. So we are dedicating this symposium to the honor, to the memory of Dr. Reinke, and we are grateful that members of the family are in presence today. I wanted to just indulge you for just 1 minute in providing a personal reflection of my connection to this topic and field. One of my first empirical papers in the literature, it was actually in looking at the burden of disease. And how do you measure burden of disease with another giant in the field of health systems, Professor Richard Morrow, who unfortunately also passed away. And this is important because we started grappling with measurement issues. And very early on at the same year, in fact, the HIV/AIDS epidemic was reaching South Asia. And so I started exploring how health systems in Pakistan were responding to that. And it's interesting. And I think maybe the speakers to follow me might reflect on this, that how do you measure changes in health systems and how do health systems respond to challenges? And we've seen so many challenges being imposed, in fact, remain a continuing theme of future health systems. I hope that in the course of this symposium, we will get to explore what are some of the macro and micro contextual forces that shape health systems of the future. And not only that, but how can health systems, in fact, constantly keep a dynamic orientation so that they understand these changes and respond to them? And I know that our guest speaker today will certainly want to reflect on not only the content, but also how do we prepare leaders for the future. So I'd like to welcome you all again to this seminar, and it's my great pleasure now to introduce Professor David Peters. Dr. Peters is the chairman of the Department of International Health and continues this honorable legacy of chairing this department, which is now over 50 years old. And I will request him to give a few thoughts and then introduce our speaker for today. David.
Thank you, Adnan. So, sometimes if you're a Calvinist, you sometimes have to suffer a lot or sometimes a little before you can truly appreciate what celebration means. And I think we've done through a little bit of that. We've had to reschedule, and people have done amazingly well in helping to reschedule. I know that we're, coming up against some biostats exams, so students are suffering now as we speak, going through their biostats exams. We actually had another speaker who is going to be joining us, Dr. Soji Adei, who's one of the directors at the World Bank. Unfortunately, he is on a plane to Tokyo as we speak, and so we couldn't keep him here or channel him here. So we've had to adjust a little because of the snow, and I'm sure that it's going to be all the better because of what we've gone through. But I also want to say that we're doing this also in memory of Bill Reinke, and so this is a much greater loss to our department and to the field, but also one that we can look back on with great pride and fond remembrances for both his personality and his personal interests, as well as his contributions. Dr. Reinke was a mentor and advisor to both Ghaffar and to Soji, as well as to me, and just wanted to spend a couple minutes just remembering about a little bit about Dr. Reinke. To be honest, the things that I remember most are his sense of humor, a very wry sense of humor, very kind man. I remember we worked together for months in Nigeria with trying to do health planning with state and local health planners. And he used to say this was an opportunity to plan without data. And coming from a man who spent his life working on data and how to use it, this was quite a big leap for him. We were together thrown off of planes in Nigeria, waiting to go to sites, and I've been thrown off with worse company than Dr. Reinke. He was also a very kind mentor. I did my dissertation work in Sri Lanka, and while I was collecting data, he did come out, and it was very helpful, not just to how to understand data, but he was always forward thinking in terms of where would this take you in terms of analysis. And again, very, very useful in that sense. And Bill was actually one of the most organized and systematic thinkers that I knew. And for every problem he saw, a process or a framework, every piece of data that he could find was at his disposal and could be used for some way to address those terms that Adnan has already pointed out. He did try and find a way of quantifying things, and again, that way of organizing thinking is something that has created a legacy in this department and in the area of health systems as I think we move forward. Looking back now at the Centennial celebrations, this is a fantastic year and a half, I guess, of Centennial celebrations, and it's just it's encouraging to think and to note that that in fact from its very beginning, this school has been involved in global health and with an outward reach to around the world. And when this department was first formed in 1961, and became the first academic program in this field, it's not like we were starting from scratch. We had a long history in this area. But I would note that this department was originally founded with a grant from the precursor of USAID, and its main purpose at that point was explicitly to educate professionals who would have the skills to be able to understand and work in very different local contexts, to understand the social, political, epidemiologic approaches, and to be able to use scientific methods and to build and use local capacity. That was the orientation. But it was about using that to solve health problems, and the term they used at the time was about seeking social justice. So those values, I think, remain with us. But it was in distinction to the notion that we were just training people to transfer American technology and ideas about public health to developing countries. It really was about this building capacity together and about applying science. Some of the early work was done in terms of actually looking at health manpower. I think some of the countries originally were Peru, Taiwan, Turkey, and others. We spent a lot of time focusing on primary health care and community health. A lot is about building low-cost primary care services, about building community participation, and we're a big force behind the primary healthcare, Health for All movement. We did help do some of the, we did actually conduct some of the first cluster randomized trials in the field in this area. Bill Reinke was a big part of the designs and the analysis, as well as the functional analysis. And then we've had a long legacy of work from discovery and applications from ORS, vaccines, micronutrients, new ways of organizing systems, looking at innovations. And this is, it's really, fortunate to come to a place where you have all that history and the people that have put that together over the last 100 and then the last 50 years. So now I'd like to move forward and forward-looking a little bit, thinking about, how will we be looking at health systems in the future? I think we still have, I know we still have our values and our vision about addressing health inequities, about pursuing social justice, about applying science, building local capabilities, and working together. So I think that's something that stays at our core. But how do we address these new public health problems or new ways of looking at public health problems? A lot of focus now is about looking at universal health care. But what should this really look like in the future? Is it about just delivering basic clinical services or about health insurance? Or do we need to do a better job at looking at some of the population and public health? And if so, how will we be able to do this? I think this last couple of years when we looked at the Ebola outbreak, it really did highlight the importance of population and public health, not just here, but I think around the world. I think the lessons there was, again, the need for comprehensiveness, but not just comprehensive in clinical care, but about public health and clinical care. I think we discovered that, the real resilience in health systems actually lies in communities and their ability to adapt and respond to crises. But as we move forward, we've seen very big changes in the role of the state and private sector, roles of communities and community groups. What does this look like moving forward? How do we find new models of co-production, and co-regulation? How do we address some of the big problems that we've now created, such as around antimicrobial resistance, such as around environmental degradation and NCDs, injuries, and actually growing health inequities? I think we need to have new models, new ways of working. And one of the things I think that, we've developed a strong legacy around, say, the social determinants of health, and we're a big part of that. And at the beginning, and this has been a big part of where we've gone. But on one hand, this is a rather linear, direct cause and effect type of relationship. That still works very well. But I think moving forward, it might be more about looking at interacting systems, with feedback and cascades and all the kinds of things that systems do to behave differently. And we need to look at how health systems interact maybe with ecologic systems, with political, biological, and other social systems as we move forward and move beyond the kind of linear models that we've become so good at working with. And this is then where maybe the work on building capacity might be more about building those capabilities of adapting and learning than just about some of the important work we've done on specific interventions. So how will we be able to address the future public health systems? At our beginning of our department, we tried to build in what's now called cultural competence and lots of expertise in public health. We tried to build an approach that facilitates rather than simply dominates and tells people what to do. But these are still important approaches, but I think we need to think of how we will do that in the future. And I'm hoping that Ghaffar in his talk will give us some insights of how we might look at some of these future health systems challenges. So let me introduce Ghaffar briefly as well. As he's told me, he comes from a family of bureaucrats, soldiers, and doctors. Well, he's a doctor with took a slightly different turn. And he spent over 30 years, yes, he's trained as a physician, but he has spent most of his time in the last 30 years working in low and middle income countries, looking at different research portfolios, designing and evaluating health systems, and training people in both researchers and decision makers. A big overlap between implementers and researchers. He started off as a public health physician in Pakistan. He moved into, became Assistant Director General of, I'm going to read this now, Policy and Planning, and then Dean of the Health Services Academy, which is a national school of public health. He then moved to WHO, where he became the regional advisor for EMRO around research. And then he has, after another couple stops along the way, he is now the executive director of the Alliance for Health Policy and Systems Research, which is a major organization based at WHO in promoting the field of health policy and systems research, really been looking at ways of advancing the connection between policy and practice and using research for a number of areas. So he has established himself as a global leader in the field, somebody who makes things happen, and I'm very pleased to say that he is also our alumni, a colleague, and a friend, and so please join me in welcoming Dr. Ghaffar. You have slides on here? No, no slides. Oh, you do. They were open? Okay.
Should be open.
These would be yours?
This is the last.
Oh, that's the end?
Yeah. Yeah.
And then,
Yeah.
there we go.
Thank you, David, for these very kind remarks. And I would like to recognize the presence of the Dean. Thank you for inviting me, Dean Clegg. Thank you, David. Thank you, Adnan. And most importantly, family of Dr. Reinke. I think I'm very happy, but it makes me a little sad because I graduated on 26th of June 2000, and this is the only time I have come back to the school formally, and it's indeed pleasure, and I think things have changed over the last 15 years, but a lot of things have changed, and some of the people, some of the kind teachers has also left the school or even have left the world. But I think that's the life. We have to live with that. And here we are talking about the future, and there we have to remember them, but we have to keep on moving. So the topic which was given to me was health systems for the futures, and I think David alluded to that to a certain extent. So what I would like to just start, when the school was established in 1916, David said it. What was the real reason infection diseases ran rampant at that time? Public health services, whatever, they were weak. And there were not many trained public health professionals and leaders worldwide. And the last thing is, like, there was no concept of international aid at that time, and this is one of the things which has evolved over the years to a certain extent. There was some sort of colonial arrangement, but there was no proper ODA systems at that time. So I just wanted to put that historical perspective. So then Johns Hopkins was established, and this is, I think, from the report, which says supply trained leaders and workers at the national, state, municipal, and rural levels of public health service, provide public health and preventive medicine training for medical students and physicians. And then it also says advance the scientific knowledge of hygiene and public health. So that's the last thing. But we have to really think at each word how much the things have changed over the 100 years and what are we really contributing, what is needed to be done even at that time when the school was established or now. So I'm sorry, it was 1961, it's a typo, I could not see it. So these are the four. I will focus more on the Department of International Health, a little bit on the school. Carl Taylor, Robert Black, David Peters. So you can see the legacy of this department. It has done wonders. It has produced hundreds of students, leaders, scientists. But if you look at the leadership level, and that's where I would like to focus, and I will honestly like to look, if you look at these three leaders, Were they made chair only because they were bringing a lot of money and lot of publications, or is there any other reason? Dr. Black may be the exception, but I think that I'm pretty confident, obviously I was not part of that decision making, but that was not the only reason, and I genuinely believe that should not be the reason for most of the leadership positions. So, what is our current mission of the Department of International Health? The department seeks to understand health problems and develop affordable means of disease reduction and health protection in underserved population of the world. So the mandate of this department, at least, obviously of the school also goes, but particularly of this department goes underserved population of the world. And I think that is where I would like to emphasize. Is it like what we are teaching and training and doing the research? Is it really targeting or helping or focusing on the underserved population of the world? And when I say world, US is part of that word. I'm not saying US is not part of that word. Then to achieve this mission, we conduct research, educate scientists and health professionals, guide health policy and public health practice, and build institutional capacity that can result in sustained improved health for all. So I will come back to that. Let's look at the 2016 we are celebrating, and we are all very proud, and we are still #1 school of public health in the world. There's no question. How things have changed. Infectious diseases, either it's Ebola or Zika virus, re-emerging infectious diseases, have they changed in the 100 years? Yes, we have been able to control them either with the antibiotics or other intervention. But is it over, or is it coming back and hunting us? In the beginning, we used the word hygiene and other things. Are we coming back to the same thing by having this agreement on Sustainable Development Goals? Sustainable Development Goals certainly goes beyond epidemiology, beyond public health per se, and I think the time has come that we might consider how do we really want to restructure our teaching and training in schools of public health. To me, the major challenge for the future is what sort of health workforce we need to train if we really want to achieve SDGs or to strengthen the health services, and the biggest threat of the security threat. And still, I think there's a limited capacity of public health professionals to address complexity. And when I say complexity, as Nan was telling the slide, that the paper of Dr. Reinke, in this school or in any other school, we were taught, and we are taught right now, there's a logic model: input, output, outcome, impact. I think there's nothing wrong if you want to look at the efficiency and effectiveness, and it makes me very happy to our colleagues in the World Bank or the people who are pure economists. But it does not really work if you want to go to the field at the district level or in the Ministry of Health where the decisions are made. We have some mechanism to measure those, and we are very happy with those reports. And if really there's a academic setting, like people like you, we draw a black box and we say between the impact and the output, and say, oh, there's a black box, we have to solve it. And what exactly is that black box? Nobody is going to define, nobody wants to define, because it's a black box. But I think we have to look at that black box or anything else if we really want to strengthen the health system and achieve the universal health coverage. We need to genuinely consider our way of teaching and training in the schools of medicine and the schools of public health. The last point I want to make it, if we really want to make the word dependent what they want to do it, This was not the case 100 years ago, but right now the data shows in middle income countries up to 5% of their national health funds are coming from the ODAs. And in the low income countries, it's up to 25%. So are we going to invest resources to our teachers, to our students in the schools of public health when they go back to their countries, especially in the underserved populations, that they work with the national government, with the ministries of finance and say, okay, you should become fully independently sustainable and you don't have to look for that 5% and 25%, because that puts you into huge compromise while you are negotiating this money, which is not a lot of money, but overall things which you need to negotiate very much compromise the outcome of the health indicators. So how can we change? And as I was saying, the one way is, should we consider, and I'm not saying there's anything wrong, we have done wonders over the 100 years, and that's the reason we are #1 school of public health. And the science, but the problem is, most of us who are trained either in this school or in another school, as David was saying, I was in the academic position in another school of public health. They are wonderful epidemiologists. They do very good, like whenever there's a infection issue, they do some sort of the health system work. But are they really working to make a change which we want to have a sustainable change in the Ministry of Health? My understanding is we need to change our teaching, training, and the health workforce. One thing we are missing is we don't teach social skills. We don't teach leadership. And somebody even can imagine, and with reasonable, I think, confidence can say, that schools like Hopkins, they get A+ students, keep them here from 9 to 1 month, put a stamp, made in Hopkins, and they go out as CGPA 3.49 or 3.94, whatever they want to have it. That's wonderful. They become very good staffs of the WHO. They become very good staff of the USAID and the World Bank. They become very good staff of the Beltways offices within the DC, and sometimes even into the NGOs in the country. But to be honest, I have worked in a ministry. I have worked almost in all settings. They are not really the best for the ministries of health or even at the district health office if you want to strengthen the district health systems. So I think some or other we have to have a higher focus on social and leadership skills. And it is not which is not happening. We have talked, I remember when I was in Ministry of Health, like 20 years ago, there was a department, like a program by the WHO, which is called Community-Oriented Medical Education. And that has been going, and it remains, was like a little bit money for a community medicine professor to have a project, 2 workshops, and all those things. It has not worked. We had Alma Mater, and then we discussed, and then the time came and WHO became absolutely another medical university, and we are producing wonderful, like big reports on big data, but anybody talking district health system or primary health care became a persona non grata within the WHO. So, and the public health, as I said, I have worked as a primary care physician. I have worked as a director of medical services. I had the pleasure to work as assistant DG policy planning, and then I was in the academic setting. And now yours truly is also working in the global health. We have completely medicalized the public health. There are people at the district level, they're counting pills, they're looking at number of surgeries, maximum they're looking at number of vaccinations, antenatal care. But nobody is talking of the public health. And if you look at the report, I come from Pakistan, as David was saying. In India and Pakistan, there was a Boers Commission before 1947, and that was absolutely a report on public health and the system of like public health, regulatory systems, public health functions, whatever we call essential public health function was the core responsibility of the district health officer, district medical officer. I think it works very well still in US when you have a public health commissioners at the county level, but not in the underserved population for which we train a lot of people go and work there. So I think the last thing which we might consider changing is incentive mechanism for public health faculty. And I'm completing with complete humbleness because I have been part of teaching and training, and I have been a teaching, like a research assistant and a teaching assistant in this school. So I can't say I was a teacher, but I have a feel how it works. And I don't think it's completely true, but primarily I don't see any difference between the faculty across the street in the School of Medicine and the faculty in this School of Public Health. They're also spending days in, days out to bring the grant to succeed and then have the publication to get the credibility and the prestige needed in the eyes of the peer, which is important. There's no question. I think still there's no mechanism which can tell about a good teacher or a scientist unless you have a peer-reviewed publication. The point I'm trying to make is, can we add something to make it more beautiful? So when I read this kind letter, the word was written, one of the towering giants, Dr. Reinke's memorial. So I found this photo, and it's amazing. It covers a lot of towering giants in this room right now, and 3 of them, very dear to me, has moved on. What was so special about these people? And one of them obviously was my mentor, and he was a great man. And I can count and I can spend hours and hours telling about him. But what was so good about all of these people? If you look at the number of publications of these 3 big giants, Carl Taylor, Bill Reinke, Tim Baker. If you go to WHO today, no offense, if you have a random check and somebody says, give me the names of the 5 big professors at Hopkins, most of the people will fail. But that's true. If I ask you who are the 8 ADG and WHO, nobody knows it. So that's equally bad, but that's not the issue. It does not matter. But there were days there was ADG and WHO and the director generals like Huff and Mahler that everybody knew them. But still people remember them, not because they have like hundreds and thousands of publications. What was good in them? They have a public interest, they have a public pain, and the most important, they were like a group of friends who had a common cause to take this school. Still, I think there's a system, there are structures, but unfortunately, the structures of the incentive was coming so, I don't want to use that strong word, that everybody is worried about his or her own grants and publication, not about the overall production of the purpose which can solve the health of those which are underserved. So, and the other thing, I think they will spend a lot of time with the students. I remember Dr. Baker's going, stopping, talking, questioning. What are you doing? What are you studying? And right now, it is not. I think there are a lot of good people I don't want to name, and I know them for sure. They are, if not exactly like that, almost close to that. And some of those colleagues, like the senior professors, are in this room. But their pain was they did not want to ask us, okay, What is your grade in AP exam you took? What is your grade in this class? Are you going to attend this thing? They were concerned, are you learning? What are your future plan? If you want to do this thing, this is good that you should take this course. They will spend a time which were their time, not our time. They were not supposed to do that. Right now, unfortunately, the system is so, like I won't call, you're all American, that is a consumerism and that sort of society, that everybody is interested in their own products. Everybody is interested in their own prestige. School's prestige, obviously, when you put them together, collective prestige, make them so good. And I said, if you have a good assembly line, if you have the best product, put a stamp, take it out, you will keep on whatever you do, number one, because everybody wants to come to the Hopkins as a student. So this is the first time I met Dr. Reinke in 1993 in Islamabad. You can see like I'm almost scared sitting with him, but I was too young, too small. This was a leadership development program offered by WHO AMRO, and he was professor of health policy, planning and evaluation. And I just had an MPH, and I was Assistant Director General Policy and Planning. And the way it happens in those parts of the world, I was put his counterpart as a local assistant professor for health policy and planning. So there I had the opportunity to meet him, to talk to him, and learn from him. And the few things I want to share with you, which I still, even today, which helped me, what he taught me. And it was not that we'll sit, we are like almost peer at that time and learning. And one thing he said, like there were students, there's always a variation in student, and those sort of leadership development program, the nominations were from all the AMRO region. So somebody from the Ministry of Health of Bahrain, somebody from Oman, somebody from Iran. And they were not necessarily the brightest leaders or not necessarily the brightest scientists. And he told me that you should not be judgmental. If you are a teacher, you have to take them and accept them at level. You should not make any judgment that he or she is very bright, he or she is more articulate. Your job that you should have, and that was very different from a cultural background. Not that I was from Pakistan, but I was a very young, true bureaucrat in the Ministry of Health at that time, which we say, okay, our job is to only discriminate about individuals and make a judgment. So that's the first thing. He said, no, if you want to do this thing, take off your hat of the Assistant Director General, you're a teacher. And I think when I was a teaching assistant here, and when I was a teacher there, it helped me tremendously that you don't have to, and there's always a good and bad. And there are people who impress you, which is natural because they are bright, competent, or whatever the reason. So that was the first lesson I learned. The second lesson I learned, he said, it is not the time you spend with them in the class. You have to develop a relationship so that they can trust you, and that trust is mutual. It should be mutual trust and respect. That you genuinely respect that student and they should genuinely respect you as a teacher. It should not be artificial. And Adnan isn't from Pakistan, but he was in a very elite school. I was not in an elite school when I was as a young student. And there, the relationship of a teacher and a student was like a jailer and a prisoner. When our medical professors come, the only choice we have to say, yes, sir, yes, sir. Yes, sir. Nothing else. And you have to stand like this. Yes, sir. Yes, sir. Yes, sir. But that is where I said no. And that is what he taught me. The last thing, there are lot of things. The last thing, there was a day we have to take that whole class because part of the leadership, there's the didactics. But then we have to take to them to different like planning commission meeting, the finance ministry meeting, Ministry of Health meeting. And we were in a planning commission meeting which was on HIV/AIDS. And it was meeting conducted by Secretary Health, Chairman of Planning Commission, and some other people. And these students were observing. So in the end, the chair of the Planning Commission said, okay, you can ask question if you don't understand as a student. So they will ask different question, and it was hour and 45 minutes. At the end of hour and 45 minutes, it was over, we left, and I asked, there were a couple of not really good answers from the Planning Commission and the Ministry of Health people. And I asked Dr. Reinke, I said, you didn't make a comment. And he said, Ghaffar, their time is better not to make a comment. And that was a very, very important learning. And I think it's like, what is the time you just want to keep your mouth? No, don't say anything. So I think it is wonderful, but then I can tell you, even I think some of my closest friends don't know me, that I did my postdoc at other school, and I was asked to apply for my PhD there. And he met me and he said, Doctor, there's another chief technical advisor, Dr. R.D. Kilman, who was one of the brightest Agarwal project person from here, and he was with us, and he said he wants to do the PhD. I want to send him to Hopkins. He wants to go to other school. And I didn't have any reason. I've never been to Hopkins by that time. And then he sat with me. We had a dinner, and he explained to me how Hopkins will make a difference in my life as compared to the other school, without having any offensive thing. There's a way you say, no, very politely. And then I said, okay, I will apply. But I said, I'm not sure there. I know a professor who was my postdoc, and he said, apply. And he said, don't worry, things all over the world, it's on merit, but you apply, this is the way you have to study, you have to do GRE, you have to do TOEFL and all those things, and things will work. And then he gave me some tips how to prepare. So I worked, and then I came to Hopkins, and here I was even telling Marsha that once I met after my graduation, the 26th, and we went out for a dinner with other committee members. And that was the first time I dared to ask her, I said, have you ever seen Dr. Reinke smiling? And she said, yes, he does smile sometimes. But he was very witty. Then after that, because when I graduated, because he was a very, very serious, he was very, very methodical, and he was a no-nonsense person. Absolutely, if you, this, you have to do it, otherwise you can't work with him. So then he got second time married, and I was the only student with all these big professors from the School of Public Health. We had Carl Taylor, Dr. Henry Mosley, Bob Black, and others were there. What I'm trying to convey from this is that this is the trust and the relationship ultimately we develop as a student, and it was all based on the space he gave it to me, that I can relate to him, I can trust him, and I still have the same respect for him. Obviously, we kept on meeting after that, but I think that shows what is the role of the teacher. It is not like have a good grade and go to other, and sometime if you come across it and they say, oh, sir, I was your student in 1993, and you say, oh, great to see you. Where are you these days? And he says, I'm at that place. That's fine. We don't have to be having love affairs with everybody, but I think we can have some positive relationships. So I think now I will just move to the teaching and training. I'm sure people know the one lady is president of Brazil, not in a good shape this time. The other lady is Director General of the WHO, also not in a great shape, but relatively better than what the president is. The point here I want to say, our DG was visiting Brazil in December or November, and she met the president there, And some of you might be hearing that there's a lot of Cuban doctors who were like Brazil wanted to have them. And there was a huge like sort of a resistance and reluctance, not only from the medical community, but also from the general community. And President of Brazil asked our Director General, and she said, do you know now the community wants to have more and more Cuban doctors? And she said, really? She said, yes. And then she said, do you know why? Did you said, no, I don't know. See, the only difference, she said, wherever I go to the community, she says, as compared to our own doctors, Cuban doctors hold our hands, look into our eyes, and talk to us. And we want to have those doctors more and more. And I think that's a social skill, that's a human skill, and some or other, the doctors, including public health, we are trusting lot and lot only the machinery, technology, which is important, but I think we need to have that human touch and the social touch. Okay, so I think David has like mentioned to these current health system challenges. But I think one thing I just want to highlight, after the Ebola crisis, when I graduated in 2000, there was a Department of Health System, which I think still, there's a division of health system within the Department of International. There was a department in those days, I think infection, Neil Holt's Department of Infectious Diseases, the name might have changed. After Ebola crisis, that has gone. You can't claim I'm a health system specialist, the other person say I'm an infectious disease specialist. That's over. And I think if we really want to move forward, the school has to redesign and reconsider if we want to like target this emerging infectious diseases, what sort of health system are required, what sort of training is required, and also if we want to achieve the SDGs, we need to have a different training so that it is not in silos, but in a different ways. And then I think we need to have a cadre of health professionals who are not only bright and competent, but also have the capacity to work with the community, politicians across sectors, and national funding institutions. And I can tell you, I have worked in the government, I'm working with the WHO, I have worked in some other positions. The skills to discuss and negotiate. To write a grant is a very different skill because you're not negotiating. You go on a merit, you write something, perfect proposal. If you know the science, you can't go wrong. But if you really are you looking for a change, if you want to make sure that the results of your like peer-reviewed publication in the New England Journal of Medicine, Lancet or somewhere is used by a policymaker or practitioner, that's a very different skill. And I think it's important if we really want to move forward. And I will re-emphasize the Hopkins, where I'm a very proud alumni. You're all very proud. If we don't be bold enough, nobody else is going to be bold enough. And this is just like a food for thought that somebody, somewhere, has to consider what is the best way, because at the end, you all work for something where there's like a proven effective reward system, which is impact factor and all those things. There's no compromise to that, but somewhere we have to move forward. So one option is like, okay, we teach here epidemiology, we teach here statistics, we teach here economics, we teach here social science, and sometime like not here, many part of the world, social science has just seen few focus group discussion and few in-depth interviews, and people think, and some people who are smart, they have a one quantitative section and so it's a mixed methods. Perfect, works. But I think we have to have like a leap to move forward and say, what is health system research? What is health policy research? And this is a WHO strategy which says and preaches for changing mindset. And when we want to change the mindset, it's both for the researchers, both for policymakers, but equally good, important for the funding agencies. So to the next 100 years, as I said, Hopkins has contributed to incredible progress in public health over the past 100 years, and I think we should all be very proud. We are all very proud. and I think we should not compromise what we have done good. But next 100 years will require us to outdo ourselves and build a powerful workforce full of great scientists, great leaders, and great people. And I think together we can do it, and Hopkins have that potential. I think that was the last slide, and this is Dr. Reinke having fun with his students in Islamabad, Pakistan. Thank you very much.
Thank you very much, Dr. Ghaffar. I'm not even going to try and summarize what you said here, but constantly I was feeling as if I'm in front of my mother. There was love in the air, but within the love, there was some strict messaging going on. There was some reality testing going on here as well. And I'm so grateful that both our current chair, our former chair, and the dean is in the audience as well. So thank you very much for your words. And we know that you are a friend, and it's best to learn from friends. So thank you very much for visiting us. What we also thought was it would be very helpful to get an initial reaction of your talk, and we've invited Dr. Asha George to initiate a discussion from the floor. Dr. Asha George is an assistant professor in the Department of International Health. She comes a little bit like yourself from South Asia, but she also comes with a background in the UN system. It's a great pleasure to have her in our department. And I'd like to invite Asha to make some opening reflections on Dr. Ghaffar's talk. Asha George.
Thank you very much. It's an honor to be here with all of you here, and also a challenge following up from those very insightful remarks by Dr. Ghaffar. I share a lot. Part of the honor of being at Hopkins is really being part of an institution of generations of learning. And I do agree, I didn't have the honor of meeting Dr. Carl Taylor, but when I joined here 4 years ago, one thing that really struck me about the health systems program seminars, being at the department, I was paired with Dr. Tim Baker, was just the sense, and Dr. Morrow had his office next to me, was that yes, Hopkins is a very competitive and aggressive place. It is important to bring in your grants and publications, but at the same time, there were these people who always had their door open. And in that sense, I really felt I was joining a community. And I'm so grateful that I did, even as we face change, and time means that we're not always with the people that we'd like to spend time with. It's a great honor to be here to remember the very special people that are part of the school. In terms of what Dr. Peters and Dr. Ghaffar talked about in terms of the future of public health, I think I was struck a lot. They also drew on Dr. Reinke's core teachings, and it'll be impossible for me to cover everything. But I was struck a little bit about several points that they talked about, and I'm going to ground it in an example, a very real contemporary example that is gripping. One of the most serious challenges we're facing is the Zika virus in Latin America. And both Dr. Peters and Dr. Ghaffar noted how much have we changed and how much more do we need to change. And I was struck by, there was a letter by Monica Roa in The Lancet just a few days ago, reflecting on the recommendation that ministries of health have made to women in Latin America to postpone pregnancy for the next 6 months of 2 years. So what does that mean? That seems like a very simple recommendation. But once you unpack that recommendation, all of the things that Dr. Ghaffar mentioned here and key lessons by Dr. Reinke come to mind. Is it such a simple recommendation? Well, once we think about health systems in terms of actors, relationships, and contexts, it really could almost be seen as insensitive. Why is that? So Dr. Reinke talked about who are the beneficiaries? And Dr. Peters talked about who are the marginalized populations. Well, number one, do women get pregnant on their own? No. So it's not just up to women in terms of planning their reproductive lives. And I think in that sense, a lot of work on gender analysis has really looked at, it's not just women leaving everything up to women, but looking at their social context. And therefore, really, how do we engage with men to change gender relations at that household level? I think Monica Rowan pointed out that 59% of pregnancies in Latin America are unplanned. So what does that tell us? The context of those people's lives in terms of understanding marginalization. People might not use contraception for many reasons in terms of the very problematic context of rape and domestic violence. If we're talking about the SDGs, that's really beyond just doctors giving out contraceptives, but really taking a holistic perspective of what are all the services that need to be in place. So having a broader perspective beyond clinical services to look at sexual education, our educational systems, the power relations at the household level that negotiate that. But also looking at even services. Dr. Peters talked about how Dr. Reinke focused on human resources for health, measuring quality of care. All of those things are part of this recommendation. Because although government services might provide certain core contraceptive, maternal health, antenatal care services, something that's really pointing to what Dr. Ghaffar mentioned in terms of sensitivity in the last 2 years, we've really changed our perception of quality of care and the whole uptake of services linking to respectful care. And why are women not going back to services comes from that new appreciation that healthcare services have to have those soft skills and those elements of patient-provider interactions. And WHO just released a recommendation last year in terms of highlighting respectful maternity care as being a core part of how services are delivered. It links to, I think, an appreciation that's different from the history. Before, we really focused on government services. But as Dr. Peters and others will say, we're now in a world where we have private healthcare systems, and a lot of services that women in Latin America access reproductive healthcare services for contraception, but also for abortion services are in the private sector. And they might not be regulated. And that's a huge challenge going forward. Dr. Ghaffar talked about leadership, regulation, and the nature of the private sector. It's really important for women receiving those services, but it's an issue in Latin America, South Asia. And what are the challenges of governance for ministries of health to really be able to regulate the private sector? There are no easy answers there. I want to make 2 other points in concluding this. The other thing that's really important in terms of the way we look at health systems and mapping out actors is we tend to think of state and market, public services, private services. But I think particularly with this issue, we're also talking about broader actors that really affect the social determinants of health, and in the context of Latin America, the Catholic Church, and their influence on regulation, deciding what services should be legal, how open people can be about certain things. And that's an issue in Latin America. Obviously, fundamentalism is an issue that impacts the way public health functions in many parts of the world, but it's an area that doesn't have a lot of visibility, and that's because of the power underneath that. The last aspect I want to come to, which I think is part of the future, and I'm very proud to be in an institution that really is embracing change. And in one way, part of that is even how we look at evidence. Adnan looked at how Dr. Reinke talked about measurement, and you had to have an indicator for everything. So for the Zika virus, it's really critical in terms of it makes us look at our basic systems in terms of surveillance, the really rapid epidemiology skills we need to have to really connect the dots. And this school is really strong in developing those skill sets. But I also think there's a home here for other types of ways of looking at evidence. And in the last 2 weeks, there was a letter to the BMJ editorial board on the role of qualitative research, and it's really sparked a lot of, opened a can of worms. But I really think when we look at even things like the Zika virus and reflecting the year before with the Ebola crisis, is if we really want to support change, we also need to be more creative on how we look at evidence, and evidence for whom and for what. And in that sense, looking at how communities themselves can be part of that evidence generation. And I think Dr. Ghaffar really last year, he published at the Alliance, there's a huge guidebook on participatory action research. And really, if it wasn't for the communities with the Ebola epidemic, empowering them to change their conditions, their social conditions, looking at where mosquitoes breed. If we don't create partnerships, and research can be part of that, that's part of our future, and we need to step up to the challenge for that. So I'm going to pause there because I'm not here to make a huge speech, but I was just struck by a lot of what they were saying. We're facing them every day. And I think great leadership means looking at change and uncertainty, facing that with confidence, but not with overconfidence, and being able to look at what are the changes we need to make ourselves in terms of how we lead in public health, teaching, and research. Thank you.
Thank you. Thank you very much, Asha, for those insightful remarks. We are running a little bit late, but I would like an opportunity for at least some of you to have a question or two. Dr. Ghaffar, if you wouldn't mind coming here. And I'm going to ask for maybe a set of questions. We'll see. I'm sure there's a lot of interest, but there will be a reception immediately following this. So could I have a show of hand if you're interested in asking a quick question from our guest here? Let me see if I can take 2 or 3 and then ask him to respond. Let me know if you, hopefully I'm able to see people here. I have one here. Yes, sir.
Well, I thought that Adnan's metaphor of talking to your mother was a good thing, and you're a member of our family. So I was 20 plus years in the School of Medicine, and I go to the advisory board there where faculty are the discussions about appointment and promotions are made. And I obviously go to the one here. And I think the faculty are very different. Although publications and money are important, I think money here is never considered in terms of promotion. I mean, it's not mentioned. If it's in a letter, we take it out. But what makes this place different and special, I think, is that that our faculty and our students and our staff believe in that mission of protecting health, saving lives, millions at a time. It's part of the fabric here. So I would just say that we hear your criticisms, and I copied your slides, and I'll use them. No, I won't. But I do think that this commitment to mission, whether it's the mission of vulnerable populations or improving health millions at a time, people really do believe it here, and it's the motivating factor for people's work.
David?
Thank you. Ghaffar, we have a big mission to move our teaching onto the internet. How can we be teachers like Dr. Reinke if we're online? Do you have any insight for that?
Great question. Do I have any other question or query? Yes, right there.
Thank you. I completely agree with what you said about the importance of social skills and sort of the interpersonal experience. I'm just sort of wondering, how much do you think that can actually be taught at an educational institution versus just through professional experience?
Yeah, great. And I'll take the last one right there. The young lady there.
So you also mentioned the limited capacity of public health professionals to address complexity. So I wanted to know what the WHO is doing to address and hiring new talents and people with other capacities over years of experience.
So, Dr. Ghaffar, over to you. You have about 3 or 4 minutes to get through whichever order you feel like.
So I think, Dean, what you said is like, I fully agree. And as I said, I would have never said these things anywhere else. And no, because I think as a member of the family, I can say it, I could be reprimanded, I could be like punished, I could be praised, and that's fine. But I think it is, I know it's happening here, and we had some conversation with Dr. Peters as the chair, and we are trying to have a movement globally that this sort of like, I think commitment to the cause is something important. Structural changes and some sort of proof of concept that how these things are different from the different schools is important, so that these lessons could be translated and learned to the other parts of the world. Because I think, I tell you, Dr. Santosham is not here. Dr. Black is here. On 27th of September 1997, there was the first meeting to establish the Public Health Foundation of India. I was a PhD student, and Dr. Black was kind to send me as his emissary with Dr. Santosham. So we attended that meeting, and after 2 days, at that time there was a Secretary Health of India, something Mr. Rao, and he said, my dream is to have, like, because they were like deans of schools of public health, to have a couple of schools like Hopkins and Harvard. And I raised my hand and I said, I have the pleasure to go to both the schools, but I don't think India needs either Hopkins or Harvard. You need very different schools based on your burden of disease, based on your like social structure, based on your bureaucracy, based on your culture. And what I think Hopkins needs to do it, like to this learning which is happening, to convey to the other developing countries that this is also the way to have the faculty equally motivated, along with not only publications and those things. And I think that would be very, very important. And that learning I hear informally, but I think it needs to be made it in the public domain. And we would be very happy to work from the WHO side to make it to the other parts of the world. And I know like in China, there are some institutions who are working on that, but this is very important that we can say money and publication is not the only criteria for the promotion or retention. And then David, I don't have a clue about that answer, to be honest. So, but I think it's an important point, and let's work together and see how can we do it. But if you ask me, like, no, I'm blank. So then I think the question is, how can we have this? Is it, I tell you, like, when I don't, because I can only give my examples, I know other people, but it's easier to give my example. I was born in a village where there was no electricity and there was only a school up till 5th grade. So my dad has to always tell me, okay, you have to get a scholarship in the 5th grade. Okay, then you can go to this grade. So I said, okay, then you have to go to this prestigious college. I said, okay, I will go to that. Then you go to the medical school. So I was doing all those things, but then I had to live in the boarding schools, and that made me a little bit street smart. But it was not learning. But I think what I learned basically leadership skills was in these schools. And I always have been to like 5 schools in US, but I'm only proud of Hopkins and another school where I went to Pakistan, which was a pre-medical school, 2 years. And those are the 2 best schools because the teachers were very different. They were very concerned. They will work with you. They will change you. Everything. It's not an injection, somebody. It's not a vaccination that you become a very social. But I think they have to exploit those things. They have to tell you what are your strengths. And the most important is they have to give you that confidence before the talk. I was talking to Dr. Mosley. I will go and stand with him in the cafeteria while he was also in the queue and ask some question in the lab which I was not able to understand, and he will never get upset. He will never go to the TA's class. They are like, go there, that's the job. That's the reason the TAs are paid. He will stand there, we will walk together, and he will tell us. And I think those are the social skills. Otherwise, if they snub us there, that's done. My social skills are gone. I was very good in the epidemiological skills. But I think the last... Okay, sir? I will do it. And then I think the new talent in WHO, Madam, we are struggling to keep the old talent in WHO. But next year there's a change of regime, so we were hopeful things will change. But this is like the next 17 months. Don't ask any question about WHO. If we can survive, we'll invite you.
Well,
okay?
Well, thank you very much to you all for attending, and join me in thanking Dr. Ghaffar. Please join us for a reception outside, and you'll get an opportunity to interact more with our speaker. Thank you.